these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office, experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all, in-depth discussions.
Breaking it down into simple terms. We hold
these truths. We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Welcome back, greatest podcast on earth, everybody. And one of my favorite subjects to talk about is healthcare, and primarily because it's a nuanced subject and difficult for a lot of people to understand. So I try to break it down in easy ways for the audience, and especially complicated subjects like Obamacare. You know, like Republicans, like, we're against Obamacare. Okay, but why? Most people don't really know. There's a lot to unpack there. There's a lot of problems with Obamacare that are hard to explain in sound bites. And, you know, there's basic principles we've got to combat, like, you know, whether healthcare is a right, is a human right. And I always say, if you call it a right, that implies that somebody else has a obligation forced upon them by government to take an action. Like, so a doctor has to work this many hours at this pay in order to serve you. That was in theory what a right would mean. You know, I guess philosophers would call that a positive right, which we're not really accustomed to in America. We have negative rights. You can't do this thing to me. This is different than you have to do this thing for me. But I also say that we should agree that healthcare is a need, kind of like housing is a need and clean water is a need. And so the Republicans should be able to come up with some solutions to meet that need by using the proper forces of the market to meet it. And we do so and with all these other needs I'm talking about, whether housing or clean water or what have you. So today we have Dr. Brian Blase. Thank you for being on to kind of walk us through, I think, the problems with Obamacare, what we're coming up on with the expiration of the ACA premium tax credits expanded under the Inflation Reduction Act, so-called Inflation Reduction Act, and what that means, and how Republicans need to approach that. This complicated subject that actually matters to a ton of people, even though it's not in the news ever. Healthcare is just not up there, but it's kind of the thing that matters to you most. So I'm going to read a little bit about your bio and then just let you take it. Ph.D. Brian Blase, founder of and president of Paragon Health Institute, a research organization focused on making healthcare better for all Americans. You were also special assistant to President Trump for economic policy at the White House National Economic Council. Did you see that recent video of the chairman of the National Economic Council under Biden? Did you see that?
That was the Council of Economic Advisors.
Oh, it's different?
Yes,
okay.
Yes, I did see that.
Yeah. Couldn't explain how we borrow money and like why that's a thing. It was really sad and unbelievable. Yes. That's the kind of thing an economist needs to be able to explain. Maybe he's not an economist, who knows? You worked a lot on the Hill. You guided the House Committee on Oversight and Government Reform's Healthcare and Entitlement Program Oversight and Investigation efforts from 2011 to 2014. So, I mean, this is the height of the Obamacare debates. And you're well positioned to talk to us about this. You were also on the Senate staff there. So well positioned to help us out with this. Tell us, just kind of in layman's terms, like what the main problems are with the ACA. Like, why are Republicans against it? What is it? What did it do to our healthcare market? What have you seen over the years, how it's kind of metastasized, and what's the future of it?
Yeah, so let me try to give a simple Obamacare 101 to a very complicated, expansive law, right? Tons of regulations, subsidies, and taxes. If you look at the coverage side, so the principal goal of Obamacare was to reduce the number of people that were uninsured. Mm-hmm. And it did it in two ways. One way was to offer states an expansion of their Medicaid program, which the federal government would fund almost all of it.
All right.
The second, that wasn't the part that the Democrats really sold at the time, though, because Medicaid is generally seen as a low-quality program. Mm-hmm. They really talked about the changes that they were going to make to the individual market for insurance. This is the place where people go to buy coverage that don't get it through an employer and that don't get it through a government plan.
Yeah.
And they said, you create this robust, very healthy market for coverage. They put a bunch of regulations in place that basically required insurers to accept any applicant during an open enrollment period. And they couldn't charge sicker applicants more than healthier applicants.
Mhm.
That aspect of it would lead to what's called adverse selection spirals, where the insurance market breaks down because sick people are more likely to buy coverage, healthy
Right.
people don't drop out. So they knew that, and they put some provisions in to reduce the adverse selection.
Right. They
One
tried
was,
to tax you if you didn't want to enroll.
that's the first one. They did it. The tax penalties called the individual mandate, and it was a tax penalty on people that didn't buy the required coverage. And then they put in place a series of subsidies, mostly for lower income individuals to buy the coverage. So Obamacare launches in a whole bunch of taxes and budget gimmicks to fund all this new spending. Obamacare launches in 2014. It doesn't go well. Enrollment is well below expectations. So premiums double, deductibles soar, and insurers start dropping out of the market. And that was the situation that the Trump administration had in 2017 when it took over. And there were a lot of accusations of sabotage. The Trump administration took steps to undermine the market. Nothing resembling the truth like that. There was no sabotage.
Yeah.
The market was basically pretty stable at about 10 million enrollees through 2020. And as a measure of sort of how it went relative to expectations, I have this first figure here.
Yeah.
So the Congressional Budget Office is the entity in Washington that estimates the legislative impact. And you could see the orange line. That's the expectations that the CBO had for enrollment in the exchanges. And you can see pretty significant uptake from 2013 to 2017. And then we'd have about 25 million people enrolled in the exchanges.
Yeah.
Enrollment has not come close to what CBO expected. It's been well below that.
Why do you think that is?
Because
people are seeing it's more expensive than they thought it would be.
It's more expensive. The only people buying coverage are individuals that receive giant subsidies to purchase the coverage. The middle class individuals, premiums were too high and deductibles were too high. There was a thought that employers would drop coverage. Employers, if they stopped offering coverage, their employees could gain these subsidies to purchase in the individual market. But most employers didn't drop coverage because the quality of the individual market plans was just subpar. So a lot of very narrow network plans. So like in Texas, you can't buy an exchange plan that covers MD Anderson. If you want to buy MD Anderson, you have to buy like alternatives like short-term limited duration insurance. You can't buy plans that cover sort of the best hospitals and doctors.
But employers can. So the employer coverage, they tend to buy
right.
that.
Employer coverage tends to be much more expansive in the number of doctors and hospitals. So now let's fast forward to President Biden gets elected. And he runs on sort of reinvigorating the ACA. And the way they did that was just to increase the subsidies. Now, the way these subsidies work are they are payments directly from the Treasury to health insurance companies, not to the individual.
Right.
So they substantially increased the subsidies. They did it in the American Rescue Plan Act for 21 and 22. The Inflation Reduction Act continued those subsidies through, they're set to expire after 2025. But we have seen a significant increase in exchange enrollment. The increase in exchange enrollment has really been driven by lower income enrollees. This second figure that I have shows you the trends in enrollment by income grouping. And in the in this Biden subsidy enhancement, they've made the plans fully taxpayer subsidized for individuals under 150% of the poverty line. So they face a $0 premium for a plan that has a very little deductible. So that has driven enrollment. Now, nobody thought when Obamacare became law that this is going to be a giant welfare program that would offer fully subsidized premiums to enrollees. But what we're seeing is that half of the enrollees in these exchanges, the taxpayer is paying the entire share of the premium.
Yeah, it's definitely not. I mean, and what's the difference between that and Medicaid? is for the states that did expand Medicaid, what is the threshold on the poverty level? I thought it was pretty high.
The states that expanded Medicaid, individuals below 138% of the poverty line are in Medicaid.
Okay.
For a state like Texas that didn't expand Medicaid, individuals above 100% of the poverty line are eligible for
Okay.
the
And they're
subsidies.
going to
the
take it
Biden
if they see the deal. So, and also, I mean, inherent in all of your explanations is also, to anybody listening, I think reveals the complexity of the political situation. Because a lot of the things you're explaining here, I think to your average person are like, well, yeah, I'd rather just have it subsidized, and so I can get it for free if I'm this poor. Okay, what's wrong with that? And I guess the answer is, well, what's wrong with it is looking bigger picture at the market itself and just how unsustainable that is, and how a continued need for subsidies, and especially going to the wrong place. I think we should talk about that. Going to the insurer as opposed to the patient. Just to create an increasingly unhealthy market that can't stand on its own 2 feet. I think would that be our main complaint against it?
So the subsidies, one, they're inflationary. So if you think about it, the individual share of the premium is held constant by the subsidy design. So regardless of what the premium is, the individual only bears a small portion of it. The taxpayer picks up the difference.
Right.
So insurers are pricing in a market knowing that the individual consumer is not
And
price
that's the thing,
sensitive.
because my question is like, how do you decide the premium? You know, in a real market, you can assume that premium is decided via market forces
Through competition.
But in this case,
so when you
you'd have to have like extreme oversight into their algorithm and like how they calculate that premium.
When you don't have that much competition in certain areas, and some parts of the country in Obamacare markets, there's not that much competition. Insurers have enormous pricing power, and they're just like, if you think of insurers, 90% of the money that they're making in Obamacare, of the premiums that they're collecting, is coming from the taxpayer.
Yeah.
It's just not, I mean, you want enrollees to show that they have some, they get some value from the plan. So they weren't like paying, these lower income enrollees weren't paying a huge amount each month. They're probably paying $20 to $40 a month for coverage. If they didn't sign up when they had to pay $20 to $40 a month, it means they're not getting at least $20 to $40 a month of benefit from a plan that cost the taxpayers $500, $600, $700, $800 a month.
Yeah, no, it's not fair on a fundamental level. But what was the market before that? I mean, before Obamacare, what were these individuals going, or what were the options that were maybe developing in the market? Because again, it's I don't want to only criticize Obamacare. I want to have sort of an alternative reality that we're in favor of as well. And so what did it look like before?
So
'Cause I've never had health. I've only worked for the government, I guess. In my
the
career.
history of health insurance in the U.S. is pretty complicated, and the U.S. is one of the only countries where most people get their insurance through the workplace.
Yeah.
And it could, if you think about it, it could strike people as bizarre that our employer is in charge of selecting our health insurance. Like, what other major financial decision do we outsource to employers? The history of it is pretty interesting. Some employers were offering health insurance prior to like the 1940s, but it was very few. As in a lot of problems come out of government price controls. During World War II, the Roosevelt administration was afraid of excessive wage inflation. So they capped wage growth.
Right.
Well, what happens when government puts in place a price control is that people try to figure out how to get around the price control.
Yeah.
And the way employers got around it to attract workers was to start offering other benefits other than wages. So they started offering health insurance. And so you got workers getting health insurance through employers. And that really picked up in the 1940s and then in the 1950s. And then the IRS made the decision that the value of the employer premium contributions would be a tax-free benefit. So now there's a benefit to the worker of getting health insurance through the employer because they don't pay taxes on it. So one of the problems, there's several benefits to employer-sponsored insurance, but one of the problems is if you get sick, you lose your job. If your health insurance is tied to your job, you lose your health insurance at a time that you really shouldn't.
Right.
So in the individual market, there were products that were coming on called guarantee renewable, which meant you could renew the product at any point in time in the future and not go through medical underwriting again. So it's sort of the market figuring out what the solution would be to this problem where people get sick and lose.
'Cause it's a real
their
problem,
health
and
insurance.
that's how Obama would argue for it. It's like there's this group of people left out of that system, whether because they're unemployed or they're individual contractors, whatever the case may be. They don't fall under an employee health insurance program, and so again, we have an incentive to fix that problem, and that's what.
One of the things he did do is he exaggerated the extent of that problem. Like if you looked at the number of people that really were uninsured who couldn't get health insurance prior to Obamacare, I mean, they were estimating it was like tens of millions of people.
Yeah.
And it was a small fraction of that. One of the initial programs in Obamacare was a federally funded high-risk pool, and it was supposed to be available to people who couldn't get health insurance. And it was an embarrassment to the administration because so few people took advantage of that program at the beginning.
Yeah, I mean, I'm surprised it's not a number that we could assess accurately. I guess it's not for whatever reason. And back before Obamacare, then if you were, let's say a contractor, you have employee health insurance, there was still a market for individual health care.
Yeah.
I mean, you could still buy insurance if you wanted.
So most people, you would apply to an insurance company, you'd go through medical underwriting. As long as you passed underwriting, you'd get an offer of insurance, and it was much cheaper than what you could get under an Obamacare plan now. There were 35 states that had programs called state high-risk pools, where if you couldn't get health insurance, you couldn't get an offer of it, you would apply to the state high-risk pool, and they would get you, there'd be insurers that participate in the state high-risk pool, and you would get coverage through the state high-risk pool. A better solution to Obamacare, I mean, in retrospect, would have been, avoid all of the heavy mandates, regulations, and subsidies, and just like increased funding for state high-risk pools. So you really would just target the solution to the problem and the people that actually couldn't get health insurance.
Yeah, because I mean, it was, again, playing devil's advocate for Obamacare. Don't want to do too much, but they say, and you laid it out pretty well earlier, they say, like, here are the problems with adverse selection, and you have to make everyone has to play, just like you make everyone get car insurance. They use that as an analogy. They'll use European country comparisons, say like everyone has to buy it, so everyone has to be in it, but whether you mandate it through a tax or you just make them do it. Now our Constitution doesn't allow you to make people do it, which is why that tax disappeared. And because otherwise the market falls apart, and healthcare is unique in the sense that like healthy people don't immediately see an incentive. Then maybe that's not a good choice on their part, but they don't see an incentive to pay a few $100 a month when they could just save that money and not pay it. And maybe that's a bad idea, but people will do it. And so you're trying to tackle that issue. And those high risks, and we've come back to this in this podcast a lot, the high risk pools and the reinsurance. And so did Obamacare basically dismantle the high risk pools that states had, or did they still have them to some extent? A lot of that's transformed into reinsurance, which is kind of the same thing.
It completely dismantled them. So those 35 state high risk pools were shut down, and just the subsidy. So that federal high risk pool that I mentioned that got very few enrollees, that started, and then the Obamacare structure started in 2014. I do want to come back to what you said on the individual mandate, because the individual mandate is one of the most interesting parts of Obamacare. President Obama campaigned against the individual mandate. He made an analogy when he was in the primary with Hillary Clinton that, you're not going to improve homelessness by mandating that people buy houses. the reason,
That's a good point.
the reason, it was a good point. So why did he change his mind? He changed his mind because of the Congressional Budget Office. The Democrats had coverage and cost numbers that they needed to meet for the legislation.
Mhm.
And the CBO assumed what I'm going to call a mythical power to the individual mandate to compel people who it wasn't in their economic interest to buy insurance
Right.
to come into the market and buy health insurance. So, that was able for them to get the coverage number that they wanted
Right.
without having to spend money to do so. So you get the individual mandate. But then what we learned as Obamacare went into effect for the first 3 or 4 years was that the individual mandate was not leading people to buy health insurance.
Yeah,
because
they'd rather pay the tax.
It wasn't the middle income people that were in these exchanges. It was the low income people. So it was the subsidies that were working to get people in. The mandate was ineffective. And one of the main reasons that Republican efforts in 2017 to replace the ACA failed is because Republicans reviled the individual mandate. They were always going to look to zero out the individual mandate penalty. So every piece of legislation that they had on Obamacare repealed the individual mandate penalty. But the CBO still attributed a mythical power to the individual mandate penalty. So even though Republican proposals were spending almost as much money as was in the baseline, CBO would come out with a top line that these proposals were going to lead 20 million more people to not have health insurance. And it was then the leading talking point for congressional Democrats who were opposing what was going on.
Yeah, I wasn't in Congress during that time, but it was a fiery time for Republicans trying to repeal Obamacare. And
so fortunately, the Obamacare, that was a legislative failure. It was a black eye. Republicans did come back and eliminate the individual mandate penalty in the Tax Cuts and Job Act.
Right.
And it didn't make a difference. So CBO was proven to be wrong in what they assumed about the individual mandate. And because when it went away, you didn't have a decline in enrollment.
It's good to have this sort of historical analysis because we've got to take another stab at this at a certain point. I don't know when the politics are going to be right for that. Voters need to be interested in it, and all voters, I don't care what side of the aisle you're on, get really skittish when you're talking about healthcare in a really, really serious way. And so we've got to be very careful about how we go about it. And I think I'm always saying one of the ways we have to do it is at least start out with a vision of how it should be, and then like carefully walk people through, like, this is how you get there, carefully, not taking anything away or not canceling anything. There has to be some acceptance of what exists now, but how to change it properly. And so maybe we can talk about that for a second. Like go back to the whiteboard. You can make kind of whatever policy you want, and maybe I don't know. Let's use a state like Texas as an example. How would we change things in Texas, change laws, change whatever to get to where we want? And assuming what we want is an easy to understand healthcare market, which to be fair, like the one website isn't bad for that. Okay, I'm not necessarily opposed to having one place that people go that maybe it fairly compares your insurance options. And so, maybe keep the website, but where should premiums go? Or where should subsidies go? Because we talk about things people need, like housing. The subsidy goes to the person, like pay an apartment building. I mean, you kind of do both, but you generally give somebody a voucher to buy food or housing, and then they can use that voucher. And, shouldn't healthcare be similar to that as opposed to paying subsidies to insurance companies that can kind of make their own inflationary, judgments on what that price should be? And then, does the reinsurance / risk pool need to be a part of that to fix that problem of too many sick people in a market, and also sick people not being able to get insurance in the first place, which is, again, like just from a moral perspective, we have to be solving that issue. Can't just be like, oh, well, it's too bad. I mean, you're sick and poor. It is what it is.
So great question. If your listeners are really interested in a comprehensive take on what the Republican Party should do on health reform, in late 2018, the Trump administration put out a 120-page report on reforming America's healthcare system through choice and competition.
Mhm.
It's an effort that I coordinated across sort of the executive departments, and we focused on policies that were consistent with sort of free market, limited government principles, where we want to empower individuals and promote as much competition in the marketplace and have a regulatory climate conducive to innovation.
Yeah.
I think some policies that I think Congress should consider, Paragon put out a proposal called the HSA Option a couple of years ago, and it addresses this issue where we don't want to empower the system, we want to empower the patient, and we want the system to respond to the patient,
Right.
not sort of all these middlemen and bureaucracies that we have both right next door in the Humphrey building here where
Mhm.
Department of HHS is, and then in insurance companies. So there is a Obamacare subsidy that goes to reduce the cost sharing that people pay for a plan. It reduces deductibles
Mhm.
and co-payments, but the subsidy is paid directly to the health insurance company for the insurance company to reduce deductibles and co-payments. So we've developed a option where the individual would have a choice. They could get the subsidy that way, or they could take an actuarially equivalent amount as a health savings account deposit, and then they have control over the subsidy and they can use it on the health care that works best for them. And for many lower income people, the problem that they face, like if they're on Medicaid or they're on an exchange plan, is that the best doctors and hospitals aren't taking that coverage. So they have to go to the emergency room to get their care.
Mm.
So why not give them the resources directly so that they have then the financial ability that they need to go get the care that they need from the doctor that they want?
Would that be one of the first things we do? I mean, if you have a long list of legislative items that get us to the basic vision that we would describe as a better healthcare
I
system.
think you reorient the Obamacare subsidies as much as possible away from insurers and to the individual, and then you open up options outside of Obamacare. So you say Obamacare, like it's going to exist if you need the Obamacare plan, you can enroll in the Obamacare plan, but it's really a bad product for a lot of other people. It's a bad product for small businesses.
Mm.
So let's open up options that allow more flexible benefit designs and structures outside of Obamacare. So you have sort of a structure to compete against the subsidized Obamacare.
That was kind of what Obamacare did too, is stamp out those options with short-term duration plans, the Cadillac plans, whatever those are, whatever it may be, just limiting options severely in order to force everyone into the specific markets they wanted them forced into. If you open that up while also just redirecting the subsidy to the actual patient, you actually create a market while still having a safety net.
Yep.
Which is the point, to put it simply, right? You need to have the market forces that allow for competition, innovation, which inherently means, controlling the price inflation as well, while also making sure that quality remains what it is. Worth always noting what Canada and the UK are dealing with, and Canada having your prime example of being a single payer system, Great Britain being a prime example of basically the entire country is the VA.
Yeah.
And it's not going well, and it's certainly not where you go for your rare diseases or your really innovative techniques. That's for sure. They come here, and
there's pockets of the U.S. healthcare system that are second to none, like our cardiac care, cancer survival rates, 5-year cancer mortality rates are so much better in the U.S. Than other countries. But yeah, I think you're absolutely right. We need to empower the patients, the consumers, get them more options, and give them control over the financing. I do think there's also, with all of these expanded Obamacare subsidies, it's tremendous amount of fraud and waste potential. Like if people aren't paying anything for their coverage, they can be enrolled in many cases. There's a study that actually just got forwarded to me by a reporter yesterday on Medicaid, and 20 million people enrolled in Medicaid last year did not know they were enrolled in Medicaid.
Huh. That's something.
That's
How does that even work?
So they were enrolled during the start of the public health, during the COVID, the pandemic, public health emergency, and some of them got other coverage. They got Medicaid temporarily. They would then get job. They'd get health insurance through the job, but they were kept on the Medicaid program because of requirements that Medicaid couldn't reevaluate anyone's eligibility for Medicaid during the extent of the public health emergency.
Yeah.
So the extent that you have all of these people that don't know they're on Medicaid, they're not getting any benefit from it.
Yeah.
But
is that costing us money if they're on it?
Yes, it's
How does it
costing
cost
us money because most of these individuals are enrolled in managed care plans. So the state is sending the insurance company a check for these individuals every month.
Oh, that's true. Because
and the federal government
subcontract, basically.
The federal government is underwriting that. They're
so
the federal government's paying 2/3 of it.
Wow. So okay, that's crazy. That's a really crazy.
And
fact.
that's what comes when people pay. I mean, if the plan is fully taxpayer subsidized, right, and there's just like the individual has no incentive to know what's going on.
Right.
You get sort of all of this gaming and bad actors that have just flooded into the.
It's one thing to be
healthcare
enrolled
sector.
and not costing us anything. Okay, you're enrolled, whatever. Nobody knows about it. You're not using it. You're not claiming Medicaid when you go to the doctor. So many people think, well, it's not costing the taxpayer anything then, but that's not the case because of what you just said, which is really interesting. So
insurance company profits. So we did a evaluation of insurance company profits relative to the S&P over the last decade since Obamacare has been in place, and insurance company profits are up 3 times more than the growth in the S&P over the last decade.
They definitely came out on top from that legislation based on how.
But think about because one of the things I think about is how the Democrats position themselves. Like if you think about the Medicare for All proponents, in their vision, there is no health insurance. The government is in charge of everything. So they talk very anti-health insurance company and very populist in their messaging of Medicare for All.
Yeah, that's a good point.
But look at what they actually do in terms of legislation. Like they are sending hundreds of billions of additional dollars to health insurance companies through this, through the expanded.
So is there a way to
subsidies.
estimate? You said estimated 20 million didn't know they were on it. So is there a joining estimate on how much that actually cost? Is there any way to really know that?
I mean, the average cost for a Medicaid recipient is probably like, for this population, is probably about $6,000 a year. So you're looking at over $100 billion a year.
Yeah, that's easy savings right off the bat. If you didn't know it, you probably didn't. If you didn't know you had it, you probably don't need it. You probably got it. You probably have it through some other form of insurance. It's extremely frustrating. You would think easy to fix. So can Medicaid not, by statute, not reevaluate that, or just by their own HHS policy?
So the Biden administration has made it very difficult for states to do redeterminations. They only allow them annually. So prior to sort of their regulation, states could do them more frequently. But it was a provision of the Families First Coronavirus Relief Act. So one of the piece of legislation that Congress passed in March of 2020 that said for the duration of the public health emergency, states could not do eligibility redeterminations and remove people from Medicaid. Well, Congress didn't anticipate that the public health emergency would go on and on and on. Like this is the reason the Biden administration continued it so long, because they were afraid of people losing Medicaid. So by the time they did the redeterminations, right, and they've removed people from Medicaid, most of the people that they removed from Medicaid had already had other coverage for months or years.
What you said you're gonna testify in the Texas legislature coming up soon on Medicaid expansion. So give us the pros and cons of a state doing doing Medicaid expansion under Obamacare. Texas is obviously a non-expansion state. So we're always kind of fighting the administration on, they're always trying to make regulations that make that life harder. We operate under waivers that allow us to manipulate those dollars a little differently, support low-income hospitals, safety net hospitals. We have in my county, Harris Health, we have 2 safety net hospitals, and I try to argue like that's a better, if you're going to spend the money, shouldn't you spend it on actual infrastructure and assets that, a real place for someone to go, as opposed to the idea of having insurance, it would, and a doctor to go to, spend it on actually funding a literal place. But what's your take?
I agree with you. I actually think that government subsidies for a safety net are much more efficient if they're spent directly on the provider rather than sort of funneled through the managed care plan. The main problem, so it's different if you're looking at it from a federal perspective or a state perspective.
Mm-hmm.
From a federal, like fiscal conservative perspective, the problem with expansion is the federal government's reimbursing 90% of the cost of this able-bodied working age population. And if states are paying such a small share of the cost, states don't have good incentives to get value or be cost conscious with that. So in every state that's expanded, you've seen enrollment and spending off the charts. So it's really
easy
expensive.
for us. Yeah, very easy at the federal level to argue against it.
At the state level, the first thing is it takes resources away from the people that Medicaid is supposed to serve. So the traditional Medicaid enrollees, low-income kids, people with disabilities, seniors.
Yep.
In states that have expanded, we have pretty good research that states are taking resources away from those individuals, and those individuals are having a harder time getting appointments with doctors, so are more likely to have to go to the emergency room. So it's worse for the people that Medicaid was designed for. Like you have basically a fixed amount of providers, right?
Yeah.
So you're not doing much. You're not increasing doctors. You're not increasing nurses when you expand Medicaid. So you're just reallocating resources, and you're reallocating them away from the people that really need the safety net the most.
How could, well, that's
It's also, I would say, one other thing for the states. The federal government is going to have to deal with its long-term fiscal unsustainable situation, and there are bipartisan efforts in the past to reduce that 90% match rate to what the normal state match rate is. So a state like Texas, for most people on Medicaid, the federal government's paying about 60% of the expense. That's about what it is nationally. I think if that rate goes down, and the American Health Care Act that passed in 2017 by the House would have ended the 90% match rate. The Obama administration had a proposal that would have equalized the reimbursement rates between the expansion population and traditional population. States would be on the hook for an enormous financial cost.
All states, or just the ones that expanded?
The states that expanded.
Yeah, because they have to go back to normal.
Yeah.
States like Texas would be just the same.
Yes.
I guess if you average it out, they'd probably be better off. That would be the reward. We can never get it to them.
If you would do, yes.
Fiscally responsible.
Paragon is, we're putting out in the summer, we're going to have a major Medicaid financing proposal, because we think it's bad economics to pay able-bodied working. It's also immoral. Like the federal government should not be discriminating against low-income kids and people with disabilities in favor of the expansion population. So I think equalizing those payment rates I actually think it should be conservatives' number one entitlement priority. So we're going to have a proposal that we put out in the summer that's going to have effects at the state level and at the federal level of addressing those problems.
Yeah, that's going to be helpful. And I don't know that many of my listeners want to download your 120-page report that you're talking about, but I think it's helpful for us as we, on the healthcare subcommittee, and looking at what does our legislative path look like? I think we need to really develop that better as Republicans, given the failure to pass the ACA reforms in 2017. I'm curious. Well, I have two questions. I'm going to say both of them so that I don't forget either of them. But I'm wondering if that had passed, what do you think the market would look like now? It was difficult to explain to people. I wasn't in Congress at the time, thank God. But if somebody asked me like what exactly that bill would have done, I'm not exactly sure. And I don't think anybody ever explained it. So, which is part of the problem politically. The thing about healthcare is it is complicated, and to be honest about it, you have to explain it in a really complicated way. So what would the alternate reality look like if that had passed? And the other question, totally kind of unrelated, but you were talking about, the supply of doctors not increasing, supply of nurses not increasing. That's a whole other problem that I think we have an incentive to want to fix. I look at it, especially in the primary care section. It's just there has to be money there for a doctor to choose that specialty. So those are two separate questions. But maybe since we're still focused on Obamacare, what is
is it okay because I didn't love the
the
American Health Care Act
I don't
was.
care. I don't know.
I mean,
I would no loyalty to it.
I would say let me give you a set of policies that I think Republicans should consider to improve a lot of the problems that we have.
So we're never going to explain what was in that bill.
I mean, it would have it was not repeal and replace. So repeal and replace was a very bad description for what those efforts were.
But it was a problem because the Republican base wanted to hear that.
Yes.
And it got everybody into a lot of effing trouble because it sounds really extreme.
Mitch McConnell said, we're going to repeal Obamacare root and branch. But it became pretty clear once, we started seeing the legislative product that large parts of Obamacare would be maintained. So like the Medicaid expansion was maintained in the House passed bill, but the rate would have declined to what the normal state reimbursement rate is. That to me is one of the best policies that was in that bill. But most of the regulations in Obamacare were maintained. And I think that was done for political reasons. The one regulation that was loosened was there's a restriction on how much more insurers can charge the oldest members of the risk pool than the youngest members. It's a 3-to-1 ratio.
Yeah.
The natural ratio is 5-to-1.
I remember
so
this,
that legislation increased the ratio from 3-to-1 to 5-to-1.
Which pissed off all the old people.
Do you remember when President Trump called the healthcare bill mean?
Yeah.
So he called it mean because of that provision, plus because of the redesign of the subsidies.
Right.
The subsidy structure in Obamacare needs to be redesigned. It's very inefficient, but it's very generous subsidies for lower income people that are near 65. So really any type of rational structure that you would have to improve that, those individuals were going to get smaller subsidies. So that was a piece of it, was sort of changing.
That's a huge
the subsidy structure.
They're very active voter base.
Changing the subsidy structure and then of course eliminating the individual and employer mandates.
So it changed the subsidy structure, but not in the way we were talking about earlier, where you actually funnel the money differently.
No,
it was just lessening the subsidies.
What Republicans and the outside conservative movement was very good at was criticizing Obamacare. What they didn't do an effective job on was developing an alternative to Obamacare. And then when the election went the way it did in 2016, and you had Republican president with a Republican House, a very narrow Republican majority in the Senate, they just weren't ready to do healthcare. They should not have started with healthcare.
Yeah.
They should have taken their time on healthcare. They should have tried to get more consensus. And really, it shouldn't have even started in the House. It should have started in the Senate to figure out what you could get 50 votes for in the Senate, rather than making a whole bunch of House members take really tough votes.
Just to have it fall apart.
Yeah, and then it fell apart. So, and I think, one of the reasons that I founded Paracon is because I don't want to have a repeat of the 2017 effort.
So even if it had passed, it's not obvious that we'd be in a much better situation. It sounds like the best part of that bill was the
Medicaid changes.
The Medicaid changes, just the lowering of federal share of that.
Yes.
Which is a better incentive structure for states.
Yes. which would be a very significant and positive change, both at the federal level as well as to
Right.
not incentivize states to over provide for the expansion population and under provide for
Right.
additional
When you're saying like,
populations.
if we're just looking at going down the road here, instead of labeling some giant healthcare bill as repeal and replace, maybe we take it like one step at a time, which would be my view of it. I still think we need sort of a general way of talking about healthcare, which is I always talk about our vision. And I try to imagine like my daughter in 30 years and how she deals with the healthcare system, and I want her to be able to like grab her phone
Yeah.
out, like, or whatever, maybe it's a hologram by that point. And she's like swiping through like different doctors and there's like set values. Here's your primary care, here's your insurance options. It's very like, it's scored, it's fair, it's clear, it's obvious, what you're buying, what you're getting. There's some method of freedom of choice, and your premiums are just kept lower because of a properly implemented reinsurance plan or risk pool plan.
And then not everything has to run through health insurance. Like one of the main problems with our health policy is that too much runs
Well, that's
through
why I like direct
too
primary
much runs
care.
through health. Yeah, I
Yeah,
mean,
it's like that's a $75 a month total access to a primary care physician. That's why I'm always trying to push legislation in that direction.
yeah, I mean, some part of what you spend on healthcare should come from your income, some should come from savings, and some
Mhm.
should come from insurance. I mean, the extent, all the problems that insurance brings with moral hazard, which is, the incentive to uh, overconsume and overutilize
Yeah.
once you have insurance, they are, they lead to so much waste in our healthcare system. I do think there's a lot of potential for artificial intelligence in healthcare. So I'm pretty bullish as long as the regulators don't get in the way, that artificial intelligence has tremendous upside to improve diagnoses,
Yeah.
the patient experience.
Yeah, we had some interesting conversations on that, regarding like how's FDA going to approve, especially if you're getting really tricky with like a diagnosis.
Yeah.
And maybe they don't need to approve a whole lot if it's still approved by a doctor. I don't know, but could be a very interesting space. On increasing doctor supply, does Paragon have any ideas on that? What incentivizes doctors to go into the right professions and just increase the general supply?
Yeah, so two things. One, we think that overall there's not a doctor shortage. So if you look at the number of doctors per 10,000 people, that has been increasing. And we've added, nurse practitioners and physician assistants that can certainly
Okay.
meet some healthcare needs. But I do think you're right that the structure that's been in place with particularly how Medicare compensates specialists and primary care docs is in need of fundamental reform. So basically the AMA has a board and they determine how much cost it is for various doctors to do their certain services and procedures that they do. And that board has historically been very biased in favor of specialties as
Interesting.
opposed to primary care. So I think, yeah, it's a corrupt part of the AMA, but unfortunately CMS tends to just rubber stamp the recommendations that come out of this process. So I think that needs to be fundamentally basically blown up.
I see. So if from our perspective, legislative perspective, what would that look like? Would it look like instructing the CMS to take another look at how they do reimbursements for primary care? Simple as that, or?
I think so. I don't want to give you a wrong answer exactly on what that is, but I think probably it would be something to change the balance of that board away from specialists.
And no rural areas also have is that 1 in 10,000 ratio the case for a lot of rural areas? We hear about this problem a lot. So a lot of these doctors are probably being concentrated in where they're going to make the most money in population centers.
Yeah, I mean, that is a problem. And there's also problems with the way, actually a paper that we put out a couple weeks ago is the way the federal government measures provider shortage areas is a problem. Honestly, I think we should, very sympathetic to foreign trained medical doctors and bringing people in. They want to come into the United States to go and meet the needs of underserved areas.
Well, maybe my last question to you, is we're kind of running out of time, is, at the state level then, like what can states like Texas do within the current reality we live in? What could they do to better to serve the population while also saving money?
Sure. Happy to have this as sort of the last takeaway. It's actually the first product that Paragon produced. Was sort of a roadmap for how states could bring about reforms in their sector. Partly, there's two big programs that the states control and could improve. One is the state employee health plan. There's ways that states could bring about reforms in the state employee health plan that could sort of percolate into the entire sector. So one thing's like site neutral payments. Health plans, Medicare tend to pay more for a service delivered in a hospital than that same service delivered in an outpatient facility or a physician office.
Right.
It leads to consolidation. It leads to increased unnecessary costs. Like states should not pay hospitals more for services that could be provided in the outpatient or physician office.
So that's site neutral. I hear about that policy a lot, but that can be, there's a federal aspect to that, and there's a state aspect to that.
Yeah, I mean, it is, well, any insurance arrangement or program is going to figure out if there's additional they're called facility fees that get charged if you have services in a hospital. Our focus primarily at the federal level is we want to do site neutral payments in Medicare, but states can do site neutral payments in Medicaid. And they could do site neutral payments in the state employee health plan.
Yeah.
Obviously you'd run into some political.
Hospital associations
from the hospitals.
go crazy about that. Yeah.
Yeah. But doctors would support it for the most part. Texas expanded access to Farm Bureau plans. One of the really interesting things about Farm Bureau plans is that it's very generous health coverage. But the state doesn't regulate it as health insurance. And because the state doesn't regulate it as health insurance, Obamacare doesn't regulate it as health insurance. So it's free from state and federal health insurance regulation, which means it can be much, much more affordable, tailored to individuals.
That's an interesting case study, I guess, we should look at. What does that look like? What does that insurance program look like? This unregulated Wild West, what does it look like?
It's very interesting. And I mean, for the most part, it looks like employer provided health insurance just with, there's initial, to protect the pool, there's initial underwriting. But once you get into that coverage, you are protected from any future underwriting. So Texas joined a bunch of states like Iowa, Kansas, Indiana, that allow the Farm Bureau to sell that health insurance. But the key is, again, the state insurance commissioner is not regulating those plans sold through the Farm Bureau.
Purposefully not regulating it.
So that Obamacare doesn't apply to it.
Yeah. And who can buy that? Farmers? Or is it...
Well, I mean, anybody. So you just have to pay whatever the probably $30 annual fee to the Farm Bureau, and then you can buy the health insurance.
Interesting.
Through that.
A lot of people struggling to figure out what a good health insurance plan might be. Maybe could look.
Yeah, I mean that's one of the, I know that another person that's testifying next week is in charge of the Farm Bureau plan. So I'm interested what they say about how that's going in Texas.
Yeah, that is interesting.
And then, I mean, generally, freeing providers to best meet patient needs. So allowing them to practice to the top of their license, repealing any anti-competitive policies. Like there's certificate of need laws, which are, if you want to expand, build, supply in 35 states, you have to go to a board and get approval from that board. But the board is often dominated by the incumbent firms that would be, I mean, it's about the most anti-competitive public policy imaginable.
Yeah. Yeah. Well, those are a few options. Brian, thanks for being on.
Great.
Been helpful.
Thank you.
Nerdy, but helpful. We got through it. It's always great to have these conversations, and I think people learned a lot. And where can they, if they are interested in a lot of these documents you talked about, what website can they go to?
Yeah, thanks. ParagonInstitute.org is our homepage, and we send out a newsletter every Wednesday, so they could go and sign up for our newsletter. And we highlight our research as well as our sort of commentary on what's going on in Washington in health policy and at the state level.
Awesome. Perfect. Appreciate it.
Thank you.
Nice. All right. It's a wrap.